Hello, good afternoon and welcome for this meeting of the Healthier Communities Overview and Scrutiny Committee. Can I say thanks ever so much for attending, and also can I welcome those members of the public that are watching this via the webcasting. Can I ask all members here, if they've got a mobile phone with them, can they turn it off please? Item agenda 1, attendance.
Apologies received from Councillor Graham and Councillor Taylor.
Thank you. Item agenda 2, declarations of interest. The legal officer has emailed me to say, unfortunately, she can't come to the meeting this afternoon because she's on holiday, but she's been through the agenda and she doesn't think there's anything there that members would have to declare. But if during the meeting there is something, could you mention it then? Item agenda 3, minutes of the meeting held on the 28th of January. That starts on page 5. If I go through it just page by page, and then if you can say if you're happy with everything. So that's page 5, page 6, page 7, page 8, page 9, and page 10. Page 11 is blank. Is everybody happy that that's a true record of the meeting?
Yes.
Thank you. Item agenda 4, action sheet. Helen, can I ask you to take us through that, please?
Yes, members, there's 2 outstanding items on the action sheet. One is for frailty. We've received an update from Jill Prattlett, but she's actually going to give you a verbal update later on during the meeting. And the second is the recommendations from our last scrutiny meeting. We have received the recommendations now, and they've been sent to you earlier today. So that's those 2 items closed.
Thank you, Helen. We'll go straight on then to agenda item 5, adult services, the duty pod. We've got 3 witnesses coming in this afternoon. One is the first one is Sam Jones, who's the team leader. The second one is Mel Firminger, who's also the team leader for DFGs, and then we've got Jill Prattlett, who's the head of service. So if we can ask Sam to come in, please. Hello, good afternoon, Mel. Thanks ever so much for coming. Sam, sorry. Sorry. First of all, I thought, Sam, if you can actually just explain the system as it is now, and then we'll go into the question. So take it that I'm a resident, I've got a little old lady who lives next door to me, and I'm a bit concerned. I don't think she's quite coping too well, so I ring the council. Can you take us from there, please?
Yeah, you would. Initially it would go through our customer care section. They would take the details there. Now, they would screen there to a certain extent in relation to our eligibility criteria, and they would make a decision at that point as to whether they felt it needed to come through to the duty team or whether it was something that they could actually manage at customer care level themselves. So that might be signposting on, or it may be that it's an inappropriate referral. So they would make that decision there. At that point, if they made a decision that they felt it was appropriate to come through, that referral then comes through and is assigned through to our duty team. And the duty team from there would screen again, but you've got qualified social workers, community care workers, we've got a full-time screening officer, so they're obviously quite highly skilled, in relation to assessments on the telephone, gathering further information, so their assessments will be much more in-depth. So they would screen again. And we've got a 5 working day rule there that all screening of referrals that come through need to be completed within 5 working days. And from there, obviously, if it's an urgent response that's required, it may be that it's a welfare visit required instantly, then we would look at doing a visit, same day, day after. Quite often our responses in a crisis situation are the same day. So that's basically how it works. So it goes through our customer care system and it comes through the duty team if it's an active referral that's felt that we need to respond to.
Great. As you know, and some of us went and sat in with the duty pod last week, and first of all, can I say thank you so much for allowing us to do that. And we were very impressed with the enthusiasm they actually had for their job. So we found that particularly useful, that exercise. So can I ask you then, very open-ended question, what is the difference has the duty pod made to your team?
I think, you know, what the duty pod does is provide a very responsive, timely service to service users who are in a crisis. And I think the fact that we can do that in such a timely way obviously is a benefit to the service user. I think in terms of benefit to our team, it means that initial response is made, it's made quickly, it releases some capacity. The older person's team in particular is a very busy team. I think it's about 85% of referrals that come through the duty pod are for older people. So it releases our capacity really and allows us to be able to sort of target the referrals that we do have to allocate within older persons more effectively, because that emergency response has kind of been made at that first point. So it means that whereas previously in years past we've had waiting lists for assessments for older people, actually at the moment we have no waiting list for new assessments for older people and for what we call care management allocations, which are service users that already have a service but need a review or need an increase in service or a change of service. There's around about 12 referrals outstanding, which is very positive, really, you know, compared with how we've been in previous years. And I think that is attributed to the fact that we're providing a lot of the responses early on, you know, within the duty pod.
Since you had the duty pod, what has been the rate of the new referrals? Have they increased?
New referrals haven't increased. They've kind of plateaued really, but I think what we find is the complexity of some of the work that we have that's coming through the duty pod, you know, that sort of increases the demand on our workload really. It's a lot of work that happens is actually on existing service users that we know of, whose needs are increasing and risks are getting higher, as opposed to brand new referrals. Even though that rate is quite steady, we're certainly not seeing a massive increase. But complexity-wise, we definitely are seeing some changes, I think.
What difference has the duty pod made to the team activity?
In relation to, sorry, could you explain?
The way the teams actually work, has the duty pod made a huge difference there?
I think it definitely has. I mean, I think we're you know, as I said, we're able to be more organised really. We're able to prioritise at the point of the duty pod and screening, so we can risk manage a lot better at that point, which means that the pressure is off the teams really in terms of trying to allocate some of the cases that we need to and the referrals that we need to respond to. And it certainly feels much more organised in a process, really, and definitely, I would hope a much more positive experience for service users coming through the service also.
Veronica, I think you wanted to bring up something about the mental health referral.
Sorry, we're so close in terms of distance, you tend to forget that we do need to use this. What happens in terms of your mental health referrals? Because they do seem to be going up. Have you got sufficient staff to cope with them? Are you able to refer them on through to other mental health services? What exactly happens?
I thought I pressed. Apologies. Older persons' mental health is obviously a team that's managed separately to older persons or the duty pod. In terms of referrals that come through the duty pod, actually there's probably not as many referrals coming through directly for older persons' mental health than we had anticipated initially. But I think some of that is attributed to the mental health measure and how you sort of class an older person with a mental health need. So a lot of those service users that have a dementia, for example, are classed as an older person, tend to come through the older person's team first. So that may sort of account for why some of those numbers are low. We're doing some work on that as well with the mental health team. But they could probably answer better as to how they manage some of the referrals through to their team, to be honest. There certainly is an increase in referrals of service users with a dementia, and that we are noticing.
Nigel, do you want to come in with the service user outcomes?
That's, I suppose, the thing is, do you, what feedback do you have about from service users about achieving what they want and what they need?
We've had some feedback, which I think was included in some of the reports that you've seen, and we've collated together some feedback that we get, which has come through more on an ad hoc basis, that people tell us how they find the service, really, in terms of it being responsive. From an older person's perspective, we have looked for a number of years at trying to gather meaningful feedback, really. I mean, we've been through the process of using questionnaires and found that it really didn't get us what we wanted, and certainly the return rate wasn't very good either. We set up a project back last year where we were telephoning service users who had been through our service, and we had a list of sort of questions and discussion, and trying to make it a little bit more meaningful in gathering some feedback. So we've got that feedback. It isn't specifically in relation to the duty pod, but what it does do is take account of the initial stages that someone has contact with us. So it does ask questions around customer care, duty responses, initial responses. So we have got some of that information from service users. The issue really is the resources to be able to do some meaningful work, you know, around getting some feedback, which is what we would definitely like to do. But it's having the resources to be able to do that as well. But we're trying to gather what we can.
Consideration maybe of, say, inviting people in to have sort of like a round table discussion about it.
We could certainly consider. Yeah, we could consider that. If we could pinpoint service users or carers that were willing to do that, then that's something we could consider.
Or maybe even go directly to organisations such as, say, Age Connect or some of the carers groups, or even go to other people. I mean, just say advertise it in anywhere, basically.
Yeah. If it's specifically around getting feedback about service users' experience around the duty pod and the responses, that's something we could target some people who had been through the service, really, and see if they would be prepared to give us some feedback, which is what we try and do over the telephone. As I say, it does have resource implications if we're arranging for people to come in for meetings, but it is definitely something that we can consider doing.
I think one of the things, reading the report, we were looking to how has the duty pod impacted on the performance indicators referred to in the report? And if you're not formally gathering that information, how can you actually judge that?
Which performance indicators? Do you want to just point me to the... Just in terms of what's collected, we're obviously collecting these statistics, and these are inputted into our database by the members of the duty team. So as they're actioning a piece of work, they would be indicating, and that's where these figures come from. If it's specifically about service user feedback, we don't have percentages on that. We've got information that we've received from service users and carers, and as I said, we've got our information in relation to older people.
If you look at the report, it was paragraph 5.21 on page 22.
Yes.
Sorry.
What we were looking at is
Yeah.
what has the duty pod impacted on that graph then?
In terms of the... Sorry, let me just have a... Yeah, so in terms of you mean in terms of the service user experience and having accurate information? Yeah, and that's, you know, that's something that we're obviously going to have to look at in terms of how we gather that information and ensure that it is accurate.
Wayne, do you want to come in on the impact on team performance? Yeah, the last one. Yeah, sorry,
yeah, sorry. What impact on team performance with the duty pod? Has there been any impact on the actual team performance within the duty pod in relation to the?
What particular way? So we've talked about the impact on the teams, I guess, of the duty pod.
Yeah.
The actuals.
Sorry.
I mean, do you feel that you're doing a better job, that the more is being done, thanks to bringing in the duty pod system, that it's helped?
Yeah, no, definitely, yes, yeah. I mean, as I said, in terms of it being responsive, there would be the majority of people that come through the duty pod that need it would have a same-day response. And I think that's something that wasn't happening previously. So and also in terms of providing information and advice, because it's not just about duty responses. You know, it may be that we are signposting on, you know, customer care will have done that a little bit, but certainly we are also doing that. So again, it's timely information and advice for service users within the first couple of days of them coming through and having and making a request to us. So I definitely feel that it's made a big difference, and it has had an impact.
So you feel then that the introduction of the duty pod, you mean that you can get more out of your team than you were previously? In
terms of older persons, yeah, definitely. Yes, and as I said, it's a much more organised and responsive way of working.
Just to go back to the mental health referrals.
Yes.
Do you think if you had a CPN as part of your duty pod team, that would make a difference?
I think certainly we have some difficulties sometimes engaging with our mental health colleagues. I think particularly the way the duty pod works, we provide such a responsive service that we kind of expect that everybody else is going to respond in that way, and sometimes that isn't possible for reasons of that particular organisation, and we understand that. But I think certainly yes, if we had access to a CPN, that would definitely be a useful thing for the duty pod. Such a lot of our work, as we've said, is around older people with a dementia, and we do often need that expertise. And I think the staff in the duty pod are very skilled in that area, but sometimes we need that health input as well. So yeah, I think it would be useful.
Has this actually been explored? Because obviously you've got quite close links with frailty, haven't you?
Yes, we do.
And I would have thought as part of that and the input in, that would have been a useful way of perhaps garnering that expertise.
Yeah, and we do work closely with frailty, and we do link in, and we also link in with the mental health team as well. And in older persons, we've got a mental health nurse who is part of our older persons team, so we do have some links in.
So you've got the link in, but you haven't got ready access if you need it.
That's
the difference, isn't
That's the difference. And I think what works very well, and we've kind of proven that with the introduction of the occupational therapy posts as well, is actually sitting in the same area, talking about individual cases, having that discussion and communication is really beneficial, and that's what we don't have. So we have very helpful colleagues, who will respond, but it's perhaps not as we are responding to a situation in the duty pod.
If I can just go back to when you were talking about the performance indicators, and notably on page 21, you obviously feel that you are doing particularly well, and the situation has changed quite dramatically to what it was a few years ago.
Yeah.
Do you feel that you need to have different PIs now with a slightly different focus? And what about separating those cases that you've got where you're seeing someone or having someone coming to you with more complex needs more than once? How are you capturing that?
Got quite a loud voice anyway. Apologies. Yeah, that we need to respond to. So the adult concern really, which is why we've started looking at that data, because we weren't previously looking at it, but actually it does show our activity in those cases that are actually already open to us.
And you feel that that will help you with determining what your actual workloads are and whether you've got sufficient capacity within the team?
I think it certainly helps, and I think it gives a good indication of some of the complexity that's happening within those cases. I don't think it captures all, but it does capture a lot of the activity. Yeah.
Anybody have anything else they want to ask Sam? Sam, can I just say thanks ever so much for coming here this afternoon, and once again, thanks for allowing us to go up and visit the duty pod. And if you can pass on the committee's thanks to the staff that we met that afternoon, because we found the information they gave us was particularly useful.
Thank you very much. That's fine. Thank you. Thank you all.
Hi Mel, good afternoon. Thanks ever so much for coming here. Can I just ask before we start, when you speak, press the button, that's great. Perhaps if you can start off by explaining your role and what your job actually is, please.
Okay. Yes, I'm the team manager in the Disabled People Service. That's a multidisciplinary team. It has social workers, community care workers, occupational therapists, occupational therapy assistants, building surveyors, a clerk of works part-time, and admin support. And I've also got the independent living broker that takes responsibility for looking at direct payments and independent living fund and that sort of thing.
Great. Can you tell me what difference has the duty pod made to your team?
Well, from the occupational therapy point of view, we receive huge numbers of referrals. So you're talking of quite sort of high capacity. And what the duty pod's been able to do is manage that capacity for us in the Disabled People Service and provide a much sort of more upfront point of contact response.
One of the things we looked at, especially on, if you look at 5.3 on the report, it says inappropriate referrals. Can you explain what an inappropriate referral actually is?
Gosh, right. I guess that's a referral that may have come through where, for instance, somebody's not given their consent to that referral being made, or it's in an area where we're just not able to sort of make a response or conduct an assessment.
Can you give us an example?
Just trying to sort of struggle off the top of my... yes, I mean, we do get instances where, say, for instance, a GP will make a referral for an occupational therapy assessment, but if that's been done without the prior knowledge of the individual that's been referred and without their consent, then we might find when we make contact with that person that they don't wish it to go any further. And the same may happen with, a concerned family member that might be ringing up about their parent or another person in the family, but without their consent and agreement to that referral being made, we can't take that any further.
So we go back to my scenario I was explaining earlier with Sam. So if I'm a resident and I have concerns about my next door neighbour who I don't think is coping, when you make contact with that neighbour, if that neighbour doesn't want any intervention, that's it then, isn't it?
I wouldn't like to say that's it. I mean, if there's any advice or guidance that we can give, or even to send them anything in the post which may be something they want to consider and think about later, but it might not necessarily go any further than that.
I see, ma'am. You mentioned occupational therapists. What are the waiting times at the moment?
Right. At the moment, if I just say we deal with critical and substantial eligibility only, and when the referral comes in, the principal OT will then look at the nature of that referral, the complexity of it, and decide whether the better response may come in the first instance from a qualified OT or from an OT assistant. So for that reason, the waiting times are actually broken down into separate lists. Sorry, it's a bit of a long-winded answer to that one. So for a qualified OT who's deemed to have critical need at the moment, we've got 1 on that waiting list. And in substantial category, we've got 15. Moving on to the OT assistant, there are no critical referrals waiting to be allocated, and 38 in the substantial category. I don't know if you're aware, but Bronavon Community Housing also employs its own staff. So there's a separate list which is held for them. They've got 3 in the critical category and 46 in the substantial.
In the context then of the duty pod, how does the duty pod help with that?
Right. The duty pod is, as I say, that first point of contact. So they will be getting in touch with the person that's been referred, making sure, obviously, that they've given their consent. And by taking them through a fairly sort of well thought out set of questions, they can establish, for instance, we might be able to offer pieces of equipment there and then. They will then place that order straight away for that equipment, and that might only just need a follow-up type of review, if at all. I mean, if it's something very, very simple, it may not even need that. In some cases, they may make a referral through to Torvine Care and Repair for some very minor works to be done. So again, instead of waiting, for that home visit and a full assessment, if it's deemed sort of something that we can deal with there and then, that's what they'll do. So what they're actually doing is reducing the amount of flow, if you like, that then comes through into the Disabled People Service.
Yes, could you... I've done this so many times, so I should know better. Could you explain a bit more to us about fast track DFG clients and what exactly that means?
With the Disabled Facilities Grant, obviously at the moment anything that's deemed to be more than £1,000 in monetary value, straight up to the maximum of £36,000, it's followed exactly the same process for each and every. So it's not really taken into account what we call sort of more simple major works. So the fast tracking now is looking at the type of work that needs to be done and the value of the work. If that is up to £5,000, so we're talking between £1,000 now and £5,000, we're not doing a financial assessment, and that is endeavours to sort of speed that process up. And we're doing a sort of simplified application process. The DFG itself is quite we've got our hands, I won't say hands tied, but there is a legislative process to follow for an application. So the fast track, the simple stuff, I'm talking things here like stair lifts, for instance, simple level access showers where it's a case of taking a bath out and replacing it with a walk-in shower, those sorts of things that really shouldn't be subject to a complex process.
Yes. Talking about the value, you chose the makeup of your team. How do you say the team activity works, and the thing about the team working together?
I think we're really, really lucky in Torvine. I've got to be honest. It's a fairly unique combination then of professionals that come under DPS, and for that reason, we're not doing so many handoffs to different teams because it's all sort of dealt with within the one team. We're fortunate as well that because we've got the older person's team on the same floor, I mean, a lot of referrals will obviously be for older people. And the occupational therapists are therefore working very closely with the social workers. But the fact that we've actually got building surveyors in the team, which seems a bit of an odd combination, I know, means that those daily conversations can take place, and yeah, it just means that communication is better. It's a model that I know Welsh Government has recommended, certainly in the latest adaptations report that was published earlier this year. Again, it's referred to as a recommendation that professionals are sort of more closely working together. So for that reason, I think it's been in place since 2008 for Torvine. So we're ahead of the game.
Last question. What do you think the duty pod the difference is made to the service user? How is that improved? And also, how do you cope with the problem of what the service user wants and what we feel they need and what we can actually give them?
Sorry. The difference that it's made then for the service user, the outcome, I guess, the response from that point of referral into the council, the response to that person is so much quicker than actually coming in, being passed out to a team, waiting for capacity within that team to actually take on a referral and then sort of make contact to go out and do the visit. So, very often if people know that they're going to be spoken to within 48 hours of a referral having been made, it can reduce anxiety. It lets people know, that we are on the case, we are dealing with it. There might be information that they want to add right at a very, very early stage, which helps make decisions then for us. And the last bit.
The question of the service users' expectations measured against what we can give them as a council, you know, what, in other words, what they want and what they need. How do you square that up?
Well, I suppose at the end of the day, that's what eligibility criteria are for. And we've only got finite resources. That having been said, I still feel that there's room for creative thinking then, and it might be that a solution that suits one person might not necessarily be the solution that, you know, works for somebody else. So, but yes, needs and wants. It's a difficult one to manage. But I think when people are, if you communicate well with people and they understand the rationale for the decisions that you're making, it's not insurmountable.
What's the feedback? What's the feedback been from the service users that you have seen and receive? What's been the feedback on from service users on how they think the service is and works?
Are you talking specifically about one element of the disabled people's service, or are you talking about DFGs?
Well, just generally within the people that you work with, what's their general thing about the duty pod and then what happens afterwards?
There's been some very good, favourable feedback about the duty pod. I don't know whether Sam was able to share any of the case studies with you. So I think anybody that's going to get a more prompt service and have a real person at the end of the phone is understandably going to be more appreciative than being added to a waiting list. I know that obviously we do capture feedback regarding our performance with the duty pod, but equally we get feedback from sort of later on down the line. For instance, you know, if people have had a DFG, we routinely send out customer satisfaction surveys. And for people who are getting packages of care, when we do our reviews of those packages of care, that's the time, you know, where people can really tell us how it is and what it's like and whether it's working for them. So I think we've got, you know, several checks and balances then, put it that way, to make sure that the effort that we're putting in is actually making a difference.
And what would you say that what would you say that you are learning from the feedback you're getting from the people?
Well, it all depends, obviously, on what the feedback is. I can think of sort of instances, for example, I'm talking about DFG because that's obviously quite pertinent to the Disabled People's Service, but yeah, you know, if we're getting feedback that a particular contractor is performing poorly and we're having to sort of speed them along, it might be you know, we might be getting feedback about individuals within the team, you know, sort of how well or not, you know, they may have communicated with people. So, yeah, there's standards of workmanship. There's feedback regarding the care agencies that we use, which is very important, you know, that we feed in for contract monitoring. It's about making sure, obviously, that public funds and limited public funds are spent as efficiently as possible and people are getting the outcome that they're looking for.
How do you feel, given what you've just said and putting that in this context, How has the duty pod impacted on the performance indicators referenced in the report? I'm assuming you've seen the report.
Yeah.
Yes. Specifically, the average days to deliver a DFG.
The figures actually for Q3 on the DFG that we'll be reporting for this year are 157 days. That's end-to-end, so that's the point obviously where somebody comes in through our customer services, the point where those adaptation works are finished. And that compared to 2012, I think it is, where we were reporting well over 300 days. So, you know, we are doing our level best, shall we say, to improve the turnaround times then for DFGs. And the duty pod will help. Of course it will. If they are, I think there are some other figures available somewhere. Probably Jill might have those to illustrate the actual difference that it's made in terms of referrals which have passed back through to the Disabled People's Service for OT compared to sort of before the days of duty pod then. The difference is absolutely phenomenal, and that means that our workers in the occupational therapy service can focus much more on what's actually passed back. If you're able to sort of deal at the point of contact very early with the simple things, it means that there's less sort of coming through. It's not always necessary to make a home visit to be able to make a judgment on what people need. So that time can be freed up for people who do need the home visits and the more complex work.
Thank you.
Could I ask a question? You mentioned earlier about Bronavon, and you said Bronavon do have their own team.
Yeah.
How do your team, I would obviously think, work very closely with Bronavon?
Yes, they do. Bronavon very much wants to work with the Disabled People's Service. They don't want to work autonomously when it comes to occupational therapy and the need for adaptations in their properties. So consequently, we are still the point of contact, the first point of contact, regardless of tenure. So we're supporting all social landlords, not just private homeowners. So we're managing what's coming in, if you like, at the front door. And the Bronavon team will then regularly come to us to sift through what referrals are on their waiting list. And similarly, we have regular occupational therapy team meetings, and they attend those as well. So there's a lot of contact, there's a lot of communication, exchange of ideas, and yeah, it's sort of professional development and staying in touch. So they may be working for Bronavon, but they're very in touch with us.
Just one last question. Go back to the DFGs. You said things are improving, but if you have a look at the graph on page 21, we're still 6 from the bottom. And there was when you think Conway is 150, we're 250 odd.
Conway do not report on the occupational therapy waiting times for DFGs. They are simply taking the recommendation time, the report from the occupational therapist, and measuring the time from then till completion of the works. there's been a number of studies, I think, that have been undertaken in the last few years to try and understand about the discrepancy across Wales with the lead times for DFGs. Going back to what I said a little bit earlier, you asked about the benefits, shall we say, of being in one team and working together. It means that we're using one IT system from the point of contact through to the works being finished, and that enables us to accurately count the end-to-end times. When you're in another authority, I won't cite Conway, but you know there are others as well. If they've got completely separate directorates and their housing and social care functions are separate, they're very often working on separate IT systems that do not link up. So they're not actually joining up the dots between the very first point of contact and work's being finished. So in our defence, shall we say, I think some of these figures are quite questionable.
So you're saying that basically then the graph on that page doesn't give a true reflection of where we are compared with other authorities in Wales?
That would be what I would say, yes.
Okay, thanks. Anybody have any more questions of Mel?
I just wonder if that's the case with that PI. Is it true of some of the others as well? Which means that we're not looking at like for like across Wales.
I guess there's always that possibility, but I mean, I can only speak obviously from the Disabled Facilities Grant, which, yes, it's not very, that's quite disheartening, I think, to think we're trying to do our best to improve, but the statistics obviously still place us in the bottom quartile.
If you have a look at on page 20, the graph, yeah, have we seen the same improvement there?
Looking at the bottom, are we?
Yeah.
Yes, as I say, for 13-14, we've reported 269 calendar days. I haven't got a crystal ball. I wouldn't want to sort of say for definite. At the quarter 3, as I say, we were standing at 157 days. So I think we'll be reporting somewhere in the region of between 157 and 160 days.
Yeah. That is encouraging. Yeah. Does anybody have anything else to bring in from? Can I just say thanks ever so much for coming, and
That's okay.
And our visit we made last week was really impressive. Thank you. Hi, Jill. Jill, can I first of all say thank you for coming and welcome you. We've been here lots of times in the past, haven't we? I think, first of all, you were going to give us an update on the action sheet, please.
On frailty?
Yes.
Yeah. I think, member, you were asking, have we now implemented the system where we could capture how clients, if clients, and how much they had improved following the intervention. Unfortunately, that has not been possible across all the CRTs, that community resource teams. What we were first led to believe was that we'd be able to input that information into the All Gwent portal system, and then we'd be able to run reports from that. That hasn't materialised. So what has actually transpired is each community resource team is almost operating a separate spreadsheet, which is very resource intensive, because what has to happen is that the practitioner involved has to record the level of functioning prior to their intervention and the level of functioning following their intervention, and then that has to be recorded. At the moment is recorded on a sheet, and then that is manually put onto a spreadsheet. Very cumbersome, not ideal at all. And if I'm honest, from a Torvine perspective, prior to frailty, when we were an intermediate care team, we had all those systems kind of integrated into our way of working, and we took them down on the back of we would be able to get that information from the portal, and so we've lost probably 3 years of data that previously would have been, we had systems in place. So, not good news, I'm afraid, Chair. But what we're doing now is almost like doing the backtrack of how we collect that information. But I think, and Helen might have more information than I do, but I mean it's a whole question of, yes, that we probably count numbers, and actually what difference. The question for me is, what difference do we make? And that's not just with the frailty data, it is with all of our performance indicators. Is more, I know there's a rationale and a reasoning for it, but it is a lot of kind of number crunching and activities. And I know the new National Outcome Framework is actually looking at the qualitative as well as the quantitative data, asking those questions, kind of what difference have we made? So the work is starting now on how we record that. And the work on our first intervention with a client, saying not just frailty, wider than that, with the wider local authority performance indicators about what they expect, and at the end of that, actually, did we deliver what they expected? So it is a wider, it's a wider issue that I know nationally we're working on, but on a local level, we haven't been able to deliver what we thought we were going to deliver from the beginning.
So, Jill, given that, are there any parameters within which you're able to work to recapture some of that data at all?
We're looking at backdating from certainly for this financial year, but what that involves in is going into individual records, client records, and looking to see how that person was functioning, and then getting that information and then putting it on a spreadsheet. So I've asked them to kind of look at that for the last 3 months, and then I have to do a judgment of actually how much time and resources is that taking, what is that going to show us, and shall we just be drawing a line and saying actually it's about going forward, because we can't afford capacity-wise to be doing that piece of work.
So, sorry to labour this, but just to be clear, when you say going forward, how do your staff, or how are they going to be working? Will they input information that they get, say, from using some kind of phone system or an iPad where they can send information in on a programme to make it easier for you, or what?
Well, initially, this is what we were hoping, that the handheld phones would be able to kind of, looking on the digital assessment forms, that we would record the information on there and as you know, that the way the digital pens work, they then will go back into the system that we'll be able to pull that off. I'm not confident that is going to happen. So what we are doing going forward is, say at the moment, kind of working on that spreadsheet. But okay, it is a bit cumbersome, but if you're doing that and people know what they're doing, what they're collecting as they're going forward, it is not so much as a chore. It's not about the backdating. So if the practitioners are very much aware of, yeah, these are the questions I'm asking on our first intervention, this is how I'm recording it, this is on our last intervention when we're closing the case, this is, you know, the questions I need to be asking and what I'm recording, and then the system then to ensure that we have that on a month-to-month basis. And I know, again, I would love to be able to say, yeah, it'd be great if people can go out and they can tick that box and send it to the system and then tick another box. But as I say, I asked that question at the beginning of frailty, or pre-frailty, is this information going to be available? And I was told numerous times, yes, it was. So I must admit, I feel quite guilty because I'm the one that said to the local, to RCRT, take our system down because I don't want you duplicating. A lesson for me.
Can I say I do sympathise because coming from a different background, I actually understood that that was what would be happening as well, so I do feel for you.
Could I ask, Jill, with the resources obviously probably tight in your department by moving people into doing that type of work, do you have the resources to manage that? My answer is we've never got spare resources. However, the way that we've configured CRT, as you know, we work 7 days a week. So we do have what I refer to as call handlers on in the community resource teams on a Saturday and Sunday. We are still working with partners and everybody really to increase the activity and the referrals on the weekend. And it's kind of like that chicken and egg stage that if you look at the data of the community resource teams, the number of referrals coming in on the weekend is quite low. So that doesn't mean that there isn't work that they can do. The practitioners can still be out in the community or on the wards doing those assessments. But for the kind of like the customer services officers who kind of take the calls, they do have some downtime at the moment on a Saturday and Sunday. So that's what we're using their time for to get some of that data back on, so that we're not wasting that resource anywhere else, really.
Okay, Jill, thanks. I think we need to move on now. We've had the report, we've read the report, and as you know, we visited last week, and thanks ever so much for allowing us to do that. The information we got there was excellent. Going on to the duty pod now, can you tell me what has been the effect of the change of the eligibility criteria in terms of demand and what impact as it has had on the duty pod?
I think you've probably all read in the report that we initially looked at expanding the duty pod because of the rise in the referrals. When we actually expanded the duty pod and then we raised the eligibility criteria, what we've seen is a reduction in the number of new referrals coming into the duty pod. And when I did kind of the new presentations of clients that we have not previously worked with, so those numbers are actually starting to reduce. However, what I would call the volume of the activity through the duty pod hasn't decreased, because by the nature of raising the eligibility criteria, the people that we continue to work with are more complex. And the more complex a client and the situation, as you would expect, the more conversations there are about with that person, with their carers, and with the other professionals. So it's kind of that traffic, and maybe that's not the right word, but I would describe it as traffic through the duty pod. how that traffic is made up has changed. So it's not those referrals, new referrals are dropping off, but the conversations are increasing. And then, so having those members of staff in the duty pod has managed to contain those conversations and traffic for a significant amount of those clients, which in turn kind of frees what I would call the back end of the social worker and the OT interventions, enable them to kind of get on with the other work rather than constantly kind of, taking the phone calls of cases that not necessarily, they're known to us, but they haven't always. We have a term called, which you probably were familiar with called open to review. So, for example, in the older persons team, we have kind of 850 cases, which you wouldn't expect those to be all allocated out to individual social workers, because they would be absolutely swamped. The prospect of coming to work every day and maybe having a caseload of 70, you'd be, whoo. So we have where clients are relatively stable, they've been reviewed, then we have, let's say, a category of open to review. So if there is a query or if there is a concern, it doesn't go direct to what I call the back-end social work. All that activity goes through the duty pod. So for me, it's kind of lined up people where they need to be to do the job that they know what their roles are. The duty pod, with the social workers and the OTs, they know what their role is. It is not to do ongoing case management. It's to provide a very quick response, information, advice, sort something where they can during the first conversation or the second conversation or a very short period. And then it's fine, great, either close that back down or open to review, or if it's a longer piece of work, they pass it to the other social workers or the OTs. So it's trying to get that streamlined, knowing exactly who's doing what at the right time.
Yeah, one thing we were particularly pleased at when we visited last week, we were told quite categorically that clients or it's clearly explained to clients that we're very sorry, you don't meet our eligibility criteria at the moment, but if anything changes, come back to us straight away. So it's not a case of a client is told, you don't meet it, so that's it. They are given the opportunity and encouraged to come back again. I think that was particularly important.
May I also add, Chair, that what I hope, I know what happens because as you probably saw, my office is right by the duty pod, so I know what's happening from expressions of people's faces or the activity. Is that if a client doesn't meet our eligibility criteria or it's a carer, yes, we would say that please come back if your circumstances change, but we would also look at kind of what voluntary services are out there and maybe direct them to the TVA. So there might be something, and the knowledge within the duty pod, we would say, actually, you don't meet our eligibility criteria, but we know this is happening in the community or that is happening, and provide the information that they could also go and access something alternatively in the interim.
Going on with that then, how do you manage clients' expectations? We go back to the question of what they want and what they need and what we can actually give them.
Sometimes with great difficulty. Part of it, and I would say that Torvine Torvine has a certain culture. It is kind of a valley culture of where people look after each other, but however there is an expectation that the council will provide. I think there'd be a different conversation if you were, and I'm just picking an example, in Tower Hamlets. The expectations are different. So I think the members of staff in the duty pod are very good at trying to explain why that people don't meet our eligibility criteria, and unfortunately, there are those cases that are escalated, where people may want to make a complaint, but then, again, that is somebody's right to make a complaint, and we would respond appropriately to that complaint. But on the whole, once people understand the rationale and it's been explained to them, then I do find people are quite reasonable. What people aren't quite rightly what people react to, if people say no, that's it, I think no, you're not entitled, and end of conversation, then people quite rightly don't like that response. So I think it's about the explanation, trying to be helpful, trying to resolve something, give people information, but that doesn't necessarily mean it has to be still provided by the social care department. But yes, it's difficult. It's also difficult for professionals. It's not just about clients and carers. GPs have expectations, district nurses have expectations, hospitals have expectations.
When we had a planning meeting on Monday, one of the things we discussed at length is the old scenario, if you intervene early enough, you will stop something escalating, and therefore it works out to be cheaper and more effective. How do we fit that in?
All members would have noted the two case studies. No, they're quite difficult to kind of quantify. But what I'd ask people to think about, and they are guesstimates, because there are a lot of different elements that impact on an outcome of an intervention. So what we've tried to do, and just to take those two case examples, is to try and guesstimate, okay, because we've gone in there earlier, try and say, okay, if we didn't have the duty pod, because say 2010, we had a completely different system in place. We had referrals coming in, we had the assistant team manager kind of doing the screening, and we had a file, and at one time, I know that when we were short-staffed, there were 60 referrals in that file waiting for allocation. Yes, they've been responded to say, yeah, we have your referral, thanks, and we will be getting back to you, but we had 60 referrals in that file. And what we found was, and what I tried to say to the staff when I said think of a case study, was, okay, what would have happened then and what happens now? And what would have happened then is it could have been 2 months before someone had a response, by which time a carer could have been at the end of their tether. We get out there and it's like, well, I just can't cope anymore. Whereas, so potentially, and it did happen, then we would arrange a respite, or we would have to put a very much bigger package of care in. And it's about crisis intervention, isn't it? It's about intervention at the right time, and you have all the theories around that. But now, I know we do get that feedback, that people feel actually, because we had such a quick response, we were happy we put a small amount of care in for a short time, and then the client and the carer were happy to let that care go, in the knowledge that, actually, I had such a good response and a quick response. If that happens again, I feel confident I can phone up and I will get a quick response, and then we can access some care again, rather than we waited 3 months and we're holding on to this care, thank you very much, because it's taken us such a long time to get it. And that's the comparison that I was trying to make, is there are some benefits to that about intervening quickly, short intervention, pull out, but with somebody then trusting the system that we'll be able to go back and provide that care.
The mental health demand, and what exactly is happening with that. Are you happy with it as it stands at the moment? Do you feel that you need to be looking to input a greater facility in the future. From what we've been told today, it looks as if the demand is lower than was anticipated, but at the same time you have got a very high number of probable people coming forward with dementia in the future.
Yes, I mean, when we first of all expanded the pod, we expected the activity for, and we're talking for older people with mental health difficulties rather than under 65, because we only look at people over 65 coming through the pod there for mental health. We were expecting greater activity. Now, whether that is the impact of the mental health measure, and it is about, there is a status through the mental health measure about a relevant patient. So what has happened is, if someone isn't deemed a relevant patient, and please don't ask me to go into the definitions of relevant patients today, they are managed through the older persons team now, rather than the mental health team. So we have seen some of so we do have clients with dementia now managed through the older persons team, not the older persons mental health team, and so it is linked to this relevant patient status. However, what we were, again, so we've been looking at that, okay, so why are the numbers coming through a lot lower? And what about the adult concerns? And there is some more work to do there, because they do have a duty worker in the mental health team, because by nature you have amps on duty and whatever they need to be going out if they're called to do a mental health act assessment. So sometimes I think they deal with the calls coming through, and rather than, and I can understand why, if you've got a person on the end of the phone, rather than transferring them, they deal with that query at the time. But I think, so what we have to do is make sure that people in the public kind of know who to contact. So if they're coming through customer care know who to direct them to. But if you've got somebody who's got the mental health number direct, they are going direct to the mental health team. And there's swings and roundabouts, because if you're a member of the public, part of this is about improving the experience of the client and the carer. So if you remember the public and you get through to someone, you don't necessarily want to hear, you need to phone this number, and if it's so that's a balance. So we need to do a piece of work on actually what kind of queries are being dealt with. But if they are holding cases, and that's kind of bogging them down and not allowing them to get on with other work, then we need to untangle that. Because I would expect some more activity coming from older persons' mental health teams.
So is that also actually in situ here, or is it within an hour in Bevan?
It's managed through the local authority, but the team is actually based up in T-Serial in County Hospital.
So it's not that easy to have as close a contact as you would have if they were also based in the area of
but
the
what
pod.
I would say is, when we looked at expanding the duty pod, one of the people that we recruited on a secondment basis was from the older persons mental health team. And she has now gone back as assistant team manager in that team. So we have got those links. So what we've done now is we have the converted was sitting in the team that we can now do some additional work, because I think that person knows the benefits that the duty pod can bring. So yes, they may not be in the same building, but the way that we work now, quite often we're not in the same building, so a lot of work is done across emails and telephone calls.
So if resources allowed it, would the ideal be that you had a CPN sat there with the duty pod?
Not necessarily. We've got an RMN, registered nurse with mental health background within the team, and that we have had that post, gosh, probably about 7 years, so that we were really forward-thinking. And we have a nurse within the team, an RGM within the team as well, so I think we were really forward-thinking in Torvine. We have a CPN within the community resource team. So we call on those resources and those expertise as it is. What I tend to hear is that where there has been an involvement of a CPN, so where we have a referral into the duty pod, and we can see that a CPN has been involved in the community, what we need to do, or what staff in the duty pod need to do, is to speak to that CPN. So it's about accessing the information that we need. So I wouldn't say necessarily that having a CPN in the duty pod would give us that information, because what we need is the information from that person who knows that client. Sorry, I'm not making myself very clear. Do you understand that?
Yeah, but going back to our visit last week, that's one of the things the staff said, that they would find that hugely
But it's a
beneficial.
conversation I need with the staff then to understand, what they get from that. So what are the problems we have at the moment? And it's certainly something I'll go back and have that conversation with the duty pod, and obviously Sam, to see, okay, what are the gaps and how can we look at that?
So is this something that you would determine as being more of a crisis situation, and you'd want it responded to within the 24 to 48 hour, in which case you do need a direct link to the CPN, don't you?
Where there is a crisis situation, then, if we have significant concern over a person's mental health and their welfare, then we would always be able to access a CPN and have some conversations around that. And it may not be that the CPN that's been assigned to that client, but likewise they could say the same about, well, actually we need you to speak to the social worker, but they're on leave. So if you have significant concerns about a client's well-being and the risks of that significant, there is always a CPN that you'll be able to talk to have that conversation. And if we were that concerned anyway, we would be initiating a mental health factors assessment anyway. Yeah.
Could I just clarify for your previous point about the assistant team manager? In the report, paragraph 410 on page 17, is that what you is that what you're referring to when you talk about the assistant team manager grade for risk management? Was that the thing that you were referring to just now?
That wasn't what I was referring to. When that 4.10, as the duty pod expanded, Sam Jones, who I think you've just spoken to, Sam took over. She had responsibility for the duty pod, but also obviously she's team manager for the older person service as well. So as I mentioned earlier, the older person service have over 800 cases, open cases. So Sam is responsible for. She doesn't know every single one of those 800 cases, although she expects of herself that she does. But when we were looking at, again, what I call the traffic through the duty pod, we needed to put somebody else in at an assistant team manager level, because the risk of all that information, because it's constant risk assessment. So I think you've had the figures about the number of new referrals and new presentations that come to the duty pod every month, and also the adult concerns, which are kind of like the telephone calls about the open cases that come through. I was concerned it was too much information for one person to be constantly processing on a day-to-day, because those decisions are like this. So that's when we looked at, there was a vacancy there, I think, so we could have reconfigured and took a report through to make that post then an assistant team manager post. But when we expanded the duty pod, there was a person that came from a mental health background into the duty pod, that she subsequently got an assistant team manager post back in mental health. So it was a different post, but that was the rationale for creating that was kind of this constant risk assessment, and it can be it's too risky for one person to manage that on a day-to-day basis.
Great. I think we should know. I think we've covered everything we wanted to on theme 1. So we go on to the second theme. Veronica.
Right. Thank you, Chair. Jill, we're looking at funding now, particularly. And we did pick up, if you look at paragraphs 4.8 and 5.25, about Invest to Save. We were wondering if you could give us greater clarity, really. Why aren't you demonstrating success in terms of Invest to Save?
I would suggest that we are demonstrating success. I think what we've said in the report is when we look to expand the duty pod, we didn't do that with any targets around savings. It was about client experience. However, I think we can demonstrate that we have had success in reducing our expenditure on what I call third-party services, so that's all the services that we commission, because despite the significant savings targets we had for this financial year, the last financial information for the end of last month, adult services were also showing an underspend of around 500,000. So we've managed to deliver that on top of our savings targets. So now I have to be very clear and say I cannot say that all that is attributable to the duty pod, because it is around the work of the community resource team, it is around the intake team, it's the duty pod, and the review team. So it is a jigsaw, but certainly the duty pod I would see as part of that jigsaw. So, but yes, we did not in the beginning say it was Invest to Save as far as reducing the spend. And I think our business case was built on the client experience and managing the risk and getting in early intervention, and we had agreement that we would use that from the social services reserve rather than a corporate reserve. Sorry, does that answer your?
I think so.
Yeah. With the reduction in the third party, how are we going to carry on referring these inappropriate referrals to other agencies?
The third party there, when I read back the report and I reflected, I think it needed to be clearer really, it is about the voluntary sector. So when I think of third party, and it was my fault the way that I kind of read the report, third party for me also includes residential nursing sector and domiciliary care. And when I read this back, for me, what I was trying to say was the voluntary sector are getting squeezed, not just from local authorities reducing their grants and their allocations, but also direct from Welsh Government and all sorts of grants and voluntary contributions. We are working with TVA to see how they can facilitate some work across the voluntary organisations in Torfaen. Like us as the authority have kind of had to look at how we can potentially share services and cut back on costs. That piece of work also needs to be done across the voluntary sector. We've we have invested in community connectors, because this is also about stimulating community activity, which doesn't necessarily have to cost money, but that takes time. And those community connectors have only been in place 9 months. I know that there is a meeting tomorrow around the Independent Care Fund, and potentially those community connectors will be, hopefully the money will be extended for another 12 months so that we can do some additional work in the communities. Because it doesn't necessarily have to be, and so that's where my wording was wrong, a building that somebody goes to, but if you have somebody in the community trying to stimulate, whether it's a self-help group or a lot, and I have to say, a significant number of clients, it is about being lonely. So how do you stimulate a community to have a conversation with somebody in this street, meeting up with somebody in that street? So it is, what I'm concerned about is that, say, there is a voluntary sector that is being squeezed, but we have to think of different ways of stimulating what's available at no cost. And I think that, I don't think we're going to get away from that, because there isn't any money from the local government. And what we also do is obviously work with colleagues in the voluntary sector, because they are sometimes able to access, whether it's lottery funding or alternative funding. So certainly I am aware of, I think many of you were aware of Gareth Cook, who works in our commissioning and planning department, where we feel that there's potential that we are looking at withdrawing money. Then we would ask Gareth to kind of work with that agency to see how he can support them in accessing money in other ways.
I think what we were particularly pleased with when we were talking to your staff, when they explained the importance of the people who provide community the meals, on what a reliable service that was. So as you go back to somebody who is lonely and perhaps nobody visits them, the fact that somebody during the day is going to knock on that person's door and make sure they're all right, and if they are concerned about them, they know where to refer them back. So we were particularly pleased with that. Success, how do you measure success?
It's whether it's success for the individual client or us as an authority. I mean, the success can be a number of different levels, can't it? I think I mentioned earlier, Chair, that I've for some time have been concerned about what we measure doesn't show have we made any difference. So for me, if the measure of success of have we made any difference, have we reduced the risk, have we increased the well-being of that person, does that person now feel safe? Those are the questions, I guess, that at the moment we do not collect that information. And as I said earlier, it is about, those are the discussions now being had in the National Outcomes Framework, that those kind of, I think it's coming out for consultation now, Helen, where there are some suggestions now, whether it be that qualitative and quantitative. All we can do, what we do locally at the moment, which I haven't reported, is that we did try to look at a pilot within older persons team to see, to kind of have that direct contact with clients to say, okay, you referred recently, and can we have a conversation about how that was about? And I picked this up earlier because I will. I'll pass that to you, Chair, just to prove that is a blank form. What we were trying to do, as said, what we've done before is kind of sent out questionnaires. We don't get many questionnaires back. They're a tick box. So really you can't pick up that much information. So we thought, well, let's try something different and just do a sample of new referrals that have been coming in, where somebody would actually, in the team, make a telephone call. Not the person that responded to them, it was actually the assistant team manager that was making a phone call to say, there's just a few prompter questions, you know, did we respond quickly, you know, what was it like, and those kind of things. Again, due to capacity issues, the person this was kind of her project, I had to move her into a different team to backfill while somebody was doing something else. So it has gone off the ball again since probably last summer. So I was discussing it with Sam earlier in the week about how we can pick that back up. So that's what we try and do to kind of get a gauge of have we made a difference. And again, recently, it was following a complaint. One of my senior officers went out to have a conversation with the complainant. And it wasn't about the complaint, but she said at the end, and the review was worthless. So took the time to explore that and say, why was the review worthless? So we've got a session, or the feedback that she was giving, we've captured that, and we're going to feed that back in, have those conversations about, okay, this is what, it's only one person, but if this is what one person is saying, we need to test out, does everybody feel like that? So we try and listen and learn, but it takes time, and that's when that member of staff, it was her project, once she was moved on, it takes time, because for it to be meaningful, and you're phoning and having that conversation, if somebody wants to take an hour to tell you what it was like, you've got to listen for an hour. You can't cut that person off. So,
does anybody have anything on theme 2? Yeah, I think we've covered everything. Shall we go on to theme 3, available support? Nigel?
Yes, Chair. A number of these issues, of course, have already been covered in funding. I think the answer maybe is if we jump to the thing about third sector provision, its accessibility, and does it depend on where you live?
Okay. Third sector, as I said, it covers a broad range. If we're looking at from when I say the lowest level, I don't mean that in a derogatory way. But in the community, for the community connectors, we have a community connector for the north and a community connector for the south. So everybody should have equal access. Residential nursing care. Yes, there are pockets, as we know, for example, in Blaenavon, where we haven't got nursing care beds. So there is an issue there. However, that is a private market that we have tried to stimulate, but haven't been successful. Domiciliary care, again, we haven't. Very occasionally, if there's a bank holiday, we might have a particular issue if somebody is right at the edge of Pontier or on the top of a mountain, but it tends to be might be a day or two that it takes to sort that. But because Torvine is small, we don't have the same issues as Powys would do with the rurality. So I'm sorry, is that the kind of information you wanted, or?
I think also one of the which actually I only thought of it yesterday. Would you be willing to that for organisations like this? Would you be willing to go outside the borough if, say, outside Torvine, say if only that a certain service was only available outside Torvine? Or it would be more convenient for the person concerned to go outside Torvine?
We commission services outside of the borough, yeah. If there's specialist services, particularly around autism, It might be, certainly there are some day opportunities that we commission in Monmouthshire, but it really is down to the individual. And for Shared Lives, for example, which is a scheme around adult respite, we have a partnership arrangement across in fact, 6 local authorities, because Merthyr are involved as well, where there might be a client in Torvine that would like respite, but they would like respite in Monmouthshire or Caerphilly. So we have that reciprocal arrangement. So yes, we would always try and source the support from inside the borough, but where it's appropriate and it's in the client's best interest, then we go outside the borough as well. We do have a system in place where whoever we commission a service from has to be on our preferred provider list. We have to satisfy ourselves that is a reputable company or whatever, so they do have to go through the appropriate checks with our commissioning department.
That would be particular if the resident moved to a different authority, like Monmouth.
Yes, I mean, again, we have a number of placements where, for example, the next of kin doesn't live in Torvine, and the client wants to be near their daughter or their son. I can remember a particular case where it took us an awful long time to sort out the ambulance to an island off Scotland, but we did it. So yes, what we would do in that case is, where it's that length of away, is we would come to an arrangement with that hosting authority that they would do the review on our behalf, so that we ensure that we have an annual review and monitoring in place, and we would pay them for that review, because it would be cheaper than sending a social worker up to one of the Isles. And so yes, we do that.
Jill, can I actually look at paragraph 5.3, page 17? Second one from the bottom, it says total screened out and not transferred to the operational teams. Can you explain what that actually means?
Total screened out, right, okay.
Basically, we just want to know where do these people go?
Okay, so if you could just give me 1 minute, because we've got the, obviously this is the duty responses. Screened out as inappropriate, no further action, signposted to other teams within social care, signposted outside of social care, and total screened out and not transferred to occupational teams. That's the one, right, okay. Sorry, I must admit, when I was going through my notes last night, I probably had the first copy which the not came out of, so that didn't trigger in my head. So my understanding of this, where you've got duty responses, there's some duty responses would be where you've got the OT kind of physically going out, and you could have the duty response being dealt with on the desk but also going out. The total screened out and not transferred to operational teams could be where it might be a one-off order of a very small piece of equipment and it's just opened and shut down. But what I would prefer to do, if you'd be happy, Chair, is to go back and get a further explanation and to ask those questions and get the detail and send that in, if that would be acceptable.
Yeah, I think so, because when we read it, we discussed it amongst ourselves and none of us could actually work out what it meant. I think the only thing we just asked you to clarify is the relationship with customer care. We've had it explained to us the system where the patient or the service user comes into customer care, then they go up. What is that triangle? How does it work? What is the relationship?
The number that the public have would be the customer care number. So once they come into customer care, they would have that conversation. The customer care would create that person on our data system, which is DRIGE, and they would get those initial details, and they would have that conversation. They would do that, almost like that first screening. It's what I would describe as that first level screening. So they might be very clear in that conversation that actually it's not social care that you would need in this case. For example, I'm sure customer care would tell you they have a number of calls for wheelchairs. Well, actually, social care department don't provide wheelchairs, and they direct them to those kind of things. We do a significant number of referrals that come in are from professionals, so it could be around district nurses and GPs, and it could be around next of kin and carers. And I haven't got the data in front of me, but the people that self-referrals are actually quite low, because I guess of the vulnerability of the nature of the clients that we deal with. So what the customer care will take all that information, and they will always ask, has this person consented? Whoever you are referring, has this person consented? So the customer care do a very good job of getting of all the information that they can, and they check the DRIGE database and whatever. When that comes through to the duty pod, it is what I call the kind of the next level of professional screening. So the member of staff in the duty pod would make contact direct with the client. So if you've got the district nurse phoning up and saying, I've been to see Mrs. Jones, really concerned because of A, B, C and D. She said, yes, you can contact me, whatever. Now we're phoning back Mrs. Jones, and we're having that direct contact then. And Mrs. Jones will quite often say, actually, I don't really want to, just tell me where I can go. I know what I need. Thank you. Thank you very much. I don't want any more information, or they do not want to contact from social services. So sometimes we get a little bit more information, which customer care have asked, but they've asked, they've been given one lot of information. When we contact the client direct, we sometimes get a different story. So it's that second level of intervention, really. We meet with customer care on a regular basis. So if there are any themes, if we feel that actually there might be an additional question that would help customer care to kind of do that additional screening, then we have those conversations. So, and again, if something comes into customer care they're particularly concerned about, they will phone the duty pod straight away, or adult protection straight away, depending on the issue. So we have a good relationship with customer care, because it's about that loop. Because if we change something within adult services, we don't tell customer care. How are they supposed to know what we're doing? I know we're now in the same building, which is good. But any changes of processes, we have to make sure that we're letting customer care know. And likewise, we also let them know if we've got particular issues on staffing, because it's setting the expectation as well. For when somebody's phoning, they might ask, how long do you think it will take to? Well, that will give them some idea.
So I think you're saying that the system is constantly being reviewed, and to make sure everybody is aware of what the situation is. That's fine. I think we're happy to move on.
Sorry. This question relates around the consultation strategy. What is your consultation strategy around gaining evidence of enhanced service user experience as a result of implementing the expanded duty pod? Sorry, can you say that again? Oh, sorry. What is your consultation strategy around gaining evidence of enhanced service user experience as a result of implementing the expanded duty pod? You've got paragraph 5.
Thank you. As I said earlier, what we've tried to do is gain the service user experience. One of the questions, what we're trying to do from the duty pod was to give clients and their carers a quick response and the information that they needed. And I think if I could refer to this questionnaire. Just some of the questions here were what we're trying to, and did we explain? So what we're asking is, was it easy for you to get in touch with us? Because that for me, that's kind of access to the service. So, all right, it does take it one step back about could they find the telephone number, but for me, it's also part of that is there's some prompts there about screening and timescales, so we want to hear their experience of did we respond to you quickly enough? And then did you feel that you were listened to? And did you get a chance to say what you wanted? That was on the second page. And how long did it take? Did you know what was going to happen next? What could we have done better? And are you happy with the end result? So, certainly the team are trying to learn from what's coming back. So when you say consultation, no, it is not a consultation in the true sense, but it is trying to listen and to change a service if it needs to be more responsive. What we haven't done is say any formal consultation or bring any groups together, and that's something that we could look at. But I think it would be probably part of maybe once a year, a wider session with a number of service users and carers to get some feedback on the whole of adult services in a number of different areas rather than just the duty pod. And I'm saying that purely on a capacity issue. If we consulted on every process and every team, I think we could have some fantastic results, but I don't think we'll be able to kind of support it capacity-wise.
Thank you. I think the other areas we've already answered.
Ask. If this has been filled out, when is this then sent to the people in the duty pod? When are the people in the duty pod told, we have talked to a certain person and they have said A, B, C and D, maybe there's food for thought. When do they get to know?
What should happen is this should be analysed every 3 months or every 6 months, and then that's fed back in. We haven't done that, as I said, unfortunately, because I've had to, the person whose project it is, I've had to move somewhere else in the short term. But what I am aware that the person did was, if there was any particular negative comments, they were put back in straight away. I mean, the person who was doing this is literally used to sit behind the duty pod, so there was that could be fed back in straight away.
Or also, if there were particular trends in what was being said if say the same themes were coming up over and over again in questionnaires.
I mean, what I will say is this covered the duty pod, but it also covered the social workers in the older persons team as well. So when they were looking, the person. Well, I shall say the person's name, Val, was making these phone calls. First of all, she would check the notes to see who did they speak to. So it might have been a social worker in the duty pod, it might have been an OT in the duty pod. Sorry, there wasn't any follow-up on the OT. This was around social work. Because I know what she tried to do was to make sure that there were that she wasn't phoning clients of a particular social worker all the time, so that she spread that to make sure that she could make phone calls to get feedback on all the social workers and the community care workers.
Joe, you'd be pleased to know this is the last area we want to look at, which is the performance outcomes. you have a look at paragraph 6.11. Can you tell me how does the duty pod improve outcomes for service users to live independently?
So 6.11, did you say? Yeah, I've got 6.11. Yeah, can I take it? Sorry, can I take it from here? Sorry, I thought it might be some kind of graph or something. I will just go back to a comment I made earlier, Chair, that where we can provide a very quick response, then we can support someone through a crisis, then we can pull back out. Where that is the first point, and I think that's the point I made earlier, that people feel they can let services go. They don't have to hang on to them if we've already shown them that they can access services quite quickly. The second part is, if we've got the duty pod right, then that enables, as I said, the other members of the team to do what they should be doing. So kind of getting on with reviews, supporting people through a longer period of crisis, because yes, people do have crises that you can go in, quick intervention and pull back out, and that might be through some medical condition, somebody's feeling unwell, or the old medical terminology of off their legs for a few days. That's fine, that's in and out. Someone else might be around a bereavement. And they need a longer time. Well, the duty pod wouldn't be supporting that person during that longer period, but it enables somebody to do a specific piece of work, get that person's confidence back up, get them back on their feet emotionally, and then pull back out, making those connections. So, as I said earlier, it's when people are left. Then you go in and then you provide, you can have 4 calls a day, and that, that's a conversation that hasn't really been had with that person about what really matters to you. Then people become dependent on those 4 calls a day. So we're not promoting their independence. So it is about people at the front on the duty pod trying to find out exactly what will help you, what will support you, and I do really feel that, unfortunately, and I wouldn't just say this for Torvine, we also, local authorities, social services department, over the last decade have been a pick off the shelf, here's 4 calls a day or here's 2 calls a day, and we have made people dependent on services. So I do think the duty pod and the way that they work, and then the way they free other people up to work, then that is how we are promoting people's independence.
I think one of the things we were very pleased to hear when we visited last week, when we were talking to the staff, and they explained that if you go in, you intervene, and then you pull out, but there's always the invitation left with the client then, if they want reassurance again, or whether they don't feel they can cope, they were actually invited to come back and say, you pulled out, I can't cope, I need you to come in again. And we were particularly pleased to hear that.
Yes, I would echo that. And sometimes there are certain clients that phone quite regularly. And they're probably the same clients that phone the GP and phone Lifeline and phone the ambulance. And between a network of phone calls, we support them. So that's.
I know I've certainly got a couple of residents in my ward who ring me on a regular basis about quite trivial things, but they're ringing for a chat, and it's quite reassuring. We've all got those.
Yes.
There was a body of work carried out by the GP I switched it off and then on, sorry. There was a body of work carried out by the GPs, I know, about 3 years ago along this basis, notably in Monmouth to start with, and it became evident that there was this cycle that would go on, but at least you're prepared for it, and they do know that they're going to get that reassurance, which I think is part of the success of it.
I think a lot of it we've already covered, unless anybody wants to bring anything else up at all. Jill, can I just say thanks again for coming. Sorry, I should have said it at the start, and I do apologise. Can I thank you for a very well-written and easy-to-understand report, because that was a huge benefit to us. And can I thank you again for allowing us to go and visit last week, and can I ask you to pass on our thanks to the committee to your staff?
And what I will do, Chair, obviously I've made a note to come back to you on the reasons why on that one particular question.
Super, thanks ever so much.
Thank you.
Great, thanks. I think we've done the scrutiny work there, and that was very informative. What we need to do is to pull together the recommendations we're going to make now. So if I hand over to Helen to take us through that process.
I think it's clear from the discussion you've had that you are satisfied that the duty pod is doing exactly what they set out to do. Do you agree with that statement? Yes. Yeah. Okay, so listening to your debate and your discussion, there are a few recommendations that I think you might want to think about. The first is around implementing a roundtable discussion to collect the views of clients on the service they've received and whether they've achieved their outcomes.
I think that was an interesting one because it was also clear that it wasn't considered to be necessarily that effective. What they seem to be doing now is quite useful if they can pool their resources.
I think it's been demonstrated, not just here, but in other areas where we scrutinise. Sending out questionnaires and things like that doesn't work because people just don't send them back again. I think the system she was talking about where somebody phones up and says, can I quickly spend 10 minutes going through, yeah. But I think there does need to be that conversation of what are we doing well, what are we not doing well, what are the customers telling us we're not doing well, to make sure, and not just the duty pod, but customer care involved in that as well, to make sure you get that triangle.
Yeah, the head one is... It's good. It's about confidence.
Yes.
Because particularly as it's such a sensitive matter.
Yes.
So, do you agree with that recommendation to discuss those issues?
I think there was the form filling. Somebody over the phone. I think somebody over the phone probably, if they went through this questionnaire over the phone, it's quite a lot for a person to take in. But then you've got 10 minutes to that and it's finished. But I think while it's down on paper and they're actually sitting one-to-one with a resident, I think that is the best way forward, to be truthful, rather than communicating with somebody who probably might be vulnerable and don't understand the question and probably can't even hear the question. And I think it's better for a person qualified to speak to a person one-to-one.
Oh, should we word the recommendation along the lines of we ask them to explore the best way possible to get the information back?
Yeah. I think there's that there, and there's also the problems that they've had through frailty with linking in with their system.
Yes.
And that really has left them with an area that's very grey at the moment. So it's very important that something's done to either set that up again in conjunction with health, or go down the pathway that they were taking before and then link in with health, so that you've got that as a backup.
Okay, so that's then explore the best methods to gauge customer satisfaction. Okay. One other thing you brought up was improve the engagement with mental health colleagues.
Yeah. I think that's particularly important, because when we visited last week, that's one of the main things. Because, you know, when we do the visit, I always leave them with, can you tell me anything that we can recommend that would improve what you're doing? And the first thing she said, if we had a CPN here, that would make a huge difference. So I take on board what Jill was saying, but I think they should at least look at the possibility of that.
If they had it on a trial basis for 3 to 6 months,
Yeah.
at least they could tell whether it was working or not.
Yeah.
The next discussion point was around performance indicators, and seeing now that the duty pod is embedded into normal practice, investigating whether the performance information they collect is still relevant, or whether they need to have new performance information.
I think that's the one that's probably the greyest of all, given when you're looking at what happens in Wales, it's quite clear that the basis aren't necessarily the same from local authority to local authority. Whether that will become less muddy with the changes in local government to take place in the future is debatable. But certainly there needs to be clarity there, and I think they should be speaking with the Ministry about it.
We've heard this for years, haven't we? But whenever we compare what we're doing with Blarney Gwent, Caerphilly or wherever, we're always not comparing exactly the same thing, because people record things differently. And quite rightly or wrongly, they will always give you the best scenario that makes them look the best. But we've constantly heard that Torvine don't actually do that. We record it as we're required to record it by the Welsh Assembly, and that's the information we put down. Hence, on that one graph, where we're 6 from the bottom, but if it was all recorded correctly, we would be near the top, hopefully.
I think that we're talking about could be two different things there. We've got national measures, which we have to collect, but also we've got our own management information that we need to collect and manage those services, and it's that information that I think is in the report with the adult concerns and things like that, and it's that information that they may need to develop as the duty pod's developed.
I think that's the thing is that unfortunately that's again right across the board. It's a problem we have. I mean the last joint scrutiny we had was at times it was like wading through treacle, going with all the various information and stuff and trying to work out.
I think what Helen was saying is the correct. We need to look at what we're actually doing. Yeah.
And what is actually relevant, because there's no point in collecting information that doesn't make sense.
It's another one really around the client, and it's something that Jill brought up, is to continue to investigate methods of measuring have we made a difference, because that's something that we're not doing at the moment. Improve the clarity of statistics collected by the duty pod, those that are in those tables. I don't think Jill had a handle on where some of those referrals were going, so I think that's something that they need to look at. Again, another one that's connected with that is to continue to investigate gaining information regarding the client experience of contact within the duty pod. And investigate using the duty pod style of working in other areas of adult services, possibly adult protection and adult mental health. I think that's all I've picked up from your discussion, so is there anything you'd like to add to that?
The thing I'd like to add is one positive side is to say how we were pleased that if a resident doesn't meet the criteria, they're not just then left hanging. They are always invited to come back if circumstances change. And also, where they put in a short-term intervention, again, the service user is then said, we're pulling out now, but if you can't cope, let us know and we can come back. I think that's important to just recognise those two points.
I think it's important because these are vulnerable adults we're talking about, and very often what can present one day as being full capacity, 2 days later can be something quite different.
And also it's the confidence you would give them, the service user, to know that they're not being left high and dry. If something does change, as you say, on a day-to-day basis, they have the facility to come back again. I think what we'll do is what we've always done in the past then. Helen and I will work on these recommendations. I'll email them out to you, give you a couple of days to read through them, see whether you want to change them or tweak them or whatever, and then we'll pass them on. Okay? So we're happy to move on then to item agenda 6, review of executive decisions for scrutiny on page 29 to 38. Go to page 33. Anybody got any comments? Page 34.
Sorry, Chair, I do need to comment.
Sorry.
On page 31, there's reference to Appendix 1, and I've put a note, where is this?
Page 35, page 36 is blank, and page 37. Okay. Item agenda 7, the discussion on the item to be taken at the next meeting. Helen, can you want to explain how we got here?
Right, the next item we're going to look at is around the Learning Disabilities Service. In the basket we had items on demand, which the duty pod is part of that, but also there's different areas of the service, such as learning disabilities, and what we're going to try and do is look at the transition from children into adulthood, but also with that there's also an opportunity for adult services and children's services to amalgamate into one service. So we're also going to look at the potential for that as well. So, and that is about demand, so it's part of the demand theme that we're looking at.
And what we'll do, obviously, the same as we've always done prior to the meeting on the 17th of June, is to look at what research we can do ahead of that, and we'll let you know.
Chair, it's prompted me to think of something that I hadn't realised was going on in our area of Cross Caerleog until very recently. And there is a Thursday group called the Crownbridge Thursday Group, which meets on a Thursday evening. And it started off initially with a former teacher of Crownbridge, and because it was opposite the old school site. And they're a mixture of adults going up to as much as 60 and ones who've just left Crownbridge School. It's quite an interesting scenario, and it might be something you'd like to look at.
Yeah, that's great. Yeah. Thank you.
As I go along and listen to them.
We found it really useful a couple of 18 months, 2 years ago, when we went to the Children's Centre in Cumbrae, and we just spent an afternoon there, and that got us a huge amount of information, and there was an awful lot going on that I certainly never knew existed until we actually went there. So going out to these sort of organisations is very informative. Next meeting 17th of June. I think that covers everything. Yep. Can I just say thanks ever so much for turning up. Okay.